Hi, I'm Brian Betts. I'm a student in the doctorate in athletic training program at Indiana State University. I'm a certified athletic trainer and also hold my CSCS. I'm going to do a little bit of a technique comparison today, going over the differences between Maitland's mobilizations and mobilizations with movement. So, what are the goals of each? The goals of Maitland mobilization is to improve range of motion and to reduce pain and improve function. Mulligan mobilization with movement is pretty much the same thing. The goal of mobilization with movement is to improve range of motion and then reduce pain within that range of motion. And also to reposition bony faults, which I don't have written down here, but Maitland is to improve arthrokinematics and osteokinematics as well, which is movement of the joint surfaces is arthrokinematics, and then the movement of the bone surfaces is osteokinematics. The big difference really being that the Maitland is generally reducing pain in the joint, and then uh, mobilization with movement is reducing pain through a range of motion. So the theories behind them, the Maitland mobilization is based on the convex-concave rule, saying how at different joints there's a rolling and a sliding motion that occur, or gliding. The convex rule is that the convex joint is moving on a concave joint. So think of like the shoulder girdle or the glenohumeral joint. The humeral head moves in the glenoid fossa, and while the joint rolls, right, to get into abduction, the head of the humerus also slides inferiorly when you're abducting. We know that the common mechanism for a shoulder dislocation is abduction and external rotation, and we know that the head of the humerus will dislocate anteriorly because with that external rotation, the head of the humerus slides to an anterior position, which is an example of that. The concave rule is a little bit different. Um, this is saying that the convex surface is moving on the concave surface is moving on a convex surface, and there's also a rolling and a sliding over the surface. So the rolling movement kind of moves around the convex surface. Think about the tibia and the femur. The tibia, when it's not weight bearing, kind of rolls around the femur, but also there's also a sliding movement as well. And when you're performing, this is integral in when you're performing Maitland's mobilizations, because as you can see in the diagram here, the roll for the concave rule and the slide is really what we're looking at. So for the concave rule, you're going to slide in the same direction as the movement. So for the tibia, if you're doing knee flexion, you're going to apply the force to the posteriorly, from anterior to posterior. On the convex rule, as you can see, the slide arrow is moving in the opposite direction of the movement. So if you think of the shoulder, and this is abduction, right, the humeral head is moving inferiorly with the slide. So when you do your mobilization, you're going to push that humeral head inferiorly to improve the range of motion. Mulligan mobilization with movement is, as you can see in this picture, one surface is stabilized. In this case, the ankle is stabilized, or the talus is stabilized. And then there's a force applied, a constant force applied to the other end of the joint. So in this respect, we're talking about the talocrural joint. There's going to be a force being applied posteriorly to the tibia, and then the patient would go through active dorsiflexion. This particular example is a weight-bearing example because the patient is standing and they are applying weight to their foot. You can also do it non-weight bearing where the patient is lying supine and the same principles apply. the patient, for this one, the patient will go through a pain-free range of motion for a designated set and rep scheme. So here, this is how it's applied. I kind of went over this in the last slide. For Maitland, the force is applied in the direction of the slide or glide, which I talked about earlier. So if we're looking at this is specific example on the bottom on that side would be a concave rule. Let me double check on that. Sorry, that would be a convex rule. And so the convex surface is having a force applied. So if you imagine a force coming up from the bottom here and pushing on that convex surface, pushing it, in this case I'll say superiorly, then that's what we're looking for. They're also performed in different grades. There's a grade 1 mobilization, which is just oscillating kind of just past neutral. It's very small oscillations. Then there's a grade 2, which is oscillating almost towards kind of like the middle range of movement from the beginning kind of to middle range. Grade 3 is from the mid-range of movement to kind of where you can kind of see you can feel the tissue take up the slack, kind of the restriction. And then grade 3 are larger oscillations. Grade 4 is small oscillations right at that end range of motion. And there's a grade 5, which athletic trainers aren't allowed to do, that's really reserved for chiropractors, and that is a high velocity, low amplitude thrust, which is technically grade 5. These are often performed in 60 seconds, sets of 60 seconds, 3 to 5 sets per week, but there really is no standard guideline. And then Mulligan mobilization, which I described earlier, so I'm not going to go over again, just the force applied throughout a range of motion. So again, there's no standard guideline for either of these. There's a lot of different variables, different methods in the research. So going through an example here of going back into the literature and looking at mobilizations to improve dorsiflexion with individuals with chronic ankle instability. So in the study that I used for Maitland's, they used grade 3 anterior to posterior joint mobilizations, 3 sets of 60 with 60 seconds with 1 minute rest in between. It was a cross-sectional design, so both of these were cross-sectional designs. There was a pre-test, intervention, post-test. For the Mulligans, they performed both weight-bearing, non-weight-bearing, and a control group, and the subjects went through the range of motion, held it for 10 seconds, and then returned to the start. And they performed 4 sets of 4 with 20 seconds of rest for both the weight-bearing and the non-weight-bearing, and the control group they just waited. There's also a control group in the Maitland's mobilization technique as well. So the patients in Maitland's, there was 30, both sets of patients had to have chronic ankle instability in both studies. The Mulligan's mobilization with movement looked at also tibial translations, and you can kind of see the respective inclusion criteria here for that. So the results, so pre-test, post-test was significant in the Maitland. So there's a improvement with the Maitland's mobilization study, and range of motion significantly increased from pre-test to post-test, and it wasn't between the control group and the intervention group. There was a significant difference in terms of improvements, with a moderate effect size of 0.41 in from pre-test to post-test. The Mulligan mobilization with movement, there was a weight-bearing and a non-weight-bearing group. They improved very well from 0.8 to 0.9 respectively mobilization with movement reduced the posterior glide by 50% in the non-weight bearing, and it reduced the posterior glide deficit between limbs by 50% in the non-weight bearing and 55% in the weight bearing group. Dorsiflexion improved with an effect size of 0.4 and 0.3, and the control had 0.1, so there wasn't much improvement with the control group. And then mobilization with movement improved bilaterally by 26, and decreased the deficit by 26% compared to 9% in the control group. And that 26% is both weight bearing and non-weight bearing. So mobilizations, what do we learn from this? Mobilization with movements and Maitland's mobilizations are both very effective or moderately effective at improving range of motion, in terms of specifically ankle dorsiflexion in individuals with chronic ankle instability. And really it depends on patient preference and clinical experience. The research says they're about equal. So if you have a patient who's non-weight bearing, maybe mobilization with movement is a little bit better, Maitland's mobilization is a little bit better because it had a little bit better effect size than the non-weight bearing mobilization with movement. So you can really your goals, you're trying to get more functional range of motion, or are you looking more at just, specifically dorsiflexion in a non-weight bearing position? Depends on what the patient wants to do, what you want to do as a clinician. And that's my references. Hopefully you took something out of this. Thank you for listening.